Hello, I'm Vicki Allen, along with Emma Kessler, Haley Elkins, and Chad O'Kane. We are EVHC consultants, and we are here to discuss an evaluation that we have prepared for the leadership team of St. Louis Children's Hospital and BJC Behavioral Health to enhance the pediatric behavioral health continuum of care. So let's start by defining the problems at hand. There is a rise in national and local trends in pediatric behavioral health conditions. There has been insufficient supply of pediatric behavioral health providers, and there is instability in the workforce, particularly in areas where behavioral health services are performed. Let's discuss the rising trends both nationally and locally. Nationally, both nationally and locally, we have seen sharp increases in pediatric anxiety, depression, suicidal ideologies, and behavioral disorders, leading to the increase of mental health diagnoses. Although there was a growing crisis in pediatric mental health before COVID-19, the nation's seen a spike during COVID-19. That has since leveled off, but is still higher than what it was previously. There are also more children presenting to emergency departments and inpatient settings suffering with high acuity levels of mental health conditions. Nationally, according to the CDC, in 2021, 21% of children ages 3 to 17 have been diagnosed with a mental, emotional, or behavioral health condition. In 2023, data of U.S. youth collected by the Maternal and Child Health Bureau indicated 20.3% of adolescents ages 12 to 17 currently have a diagnosed condition. And in 2020, the American Academy of Child and Adolescent Psychiatry named suicide as the second leading cause of death nationally for ages 10 to 24. Now, locally, 22.7% of Missouri children ages 3 to 17 have been diagnosed with ADHD, depression, anxiety, or other behavioral or conduct problems. This is higher than the national average of 19.9%. St. Louis Children's Hospital Emergency Department has seen a significant increase in patients presenting to the ED with behavioral health needs this spring when compared to that of the same period prior. With the increase in demand for behavioral health services, there is a national need for additional pediatric behavioral health providers. Locally, Missouri is no different in that need. St. Louis is surrounded by counties with 6 or less child and adolescent psychiatrists, with one of those counties having none and being considered a national provider shortage area. According to firstfocus.org, nationwide, more than 60% of children with severe depressive episodes do not receive treatment for their conditions. The need for additional providers is exacerbated by the increased demand for these services. With the rising trends in diagnosing and increase of patients to EDs, patients and families are experiencing longer wait times to be seen by a provider. EDs have higher instances in patients leaving without being seen, and EDs are keeping patients much longer waiting on other options to become available. The Children's Hospital Association estimates a need for 47 child psychiatrists per 100,000 kids and teens, but there are currently only 10 per 100,000. It is challenging for hospitals to provide appropriate and safe care because of this provider shortage and the lack of inpatient beds and opportunities for placement externally. With such a demand for these specialized providers and so few of them to meet that demand, many frontline team members are not equipped to deal with this, so there is a high instance of instability in the workplace. St. Louis Children's Hospital's RN turnover peaked during the pandemic and has leveled out at 17%, which is still higher than benchmarks. The inpatient behavioral health unit has a turnover rate of 32.7%, while the ED has a rate of 22.5%, both costing St. Louis Children's Hospital over $21,000 per position. BJC behavioral health turnover is at 15.7%, costing nearly $35,000 per position. Now I'm going to turn this over to Emma to discuss organizational structure.
Okay, for the St. Louis Children and BJC organizational shift, our goal is to create and strengthen a cohesive organizational structure. So both BJC and St. Louis Children are on the same page with their workflows, processes, specifically for the pediatric behavioral health with their inpatients and outpatients. So one of the procedures that they can turn to is a pediatric focused behavioral health service line. And this looks like bringing on a chief of pediatric behavioral health who will oversee both BJC and St. Louis Children's to help for a centralized leadership to keep everyone on the same page, keep a consistent quality of care, way of care, access, quality, and so on. This is keeping everyone on the same process, expectations, workflows, etc. This is bringing on a dashboard for system-wide metrics, which can allow for system-side strategic goals and not just department goals. This dashboard can be tracking things like quality, access, wait times, patient outcomes, etc. This would be unified policies, and this would also be consolidating departments into one cohesive behavioral health service line instead of having patients on throughout the hospital and some in various areas of the hospital. This is having them all on one department, one primary way of care, same floor, same providers, etc. Another option is a shared governance across all behavioral health departments. So compared to the previous slide where I mentioned one cohesive pediatric floor, this is keeping those same departments that specialize in behavioral health, but in different ways. This is kind of bringing each manager from those respective departments like psychiatry, outpatient health, social work, who all kind of work with pediatric behavioral health patients. This brings them to collaborate and bring a coordinated and aligned approach to care. So again, workflows, staff, quality, access. This removes the silos of one floor and one department doing it one way and a different floor and a different department doing it a different way. So this also cross-training for each department. So again, for each department's knowledge and understanding of expectations, process in any given situation, and not just kind of a free-for-all, if you will. This will make sure both BJC and St. Louis Children's are aligned regarding behavioral health care for inpatient and outpatients. So this isn't going to be where BJC is accustomed to doing it one way and St. Louis Children's is doing it a different way. This is under one leadership. This is under the same process, same workflows. Now I'll be passing it over to my colleague Chad to discuss partnerships.
Thank you, Emma. By leveraging new partnerships, BJC and St. Louis Children's can create a seamless continuum of care that enhances both outcomes and quality of care for patients and reduces the burden on emergency departments and inpatient units. Also fulfills the mission of the organization to do what's right for children and families across the region. To truly improve outcomes, the organization really must build and strengthen partnerships across the continuum of care. These partnerships will allow us to reduce wait times for behavioral health services, improve continuity of care across inpatient, outpatient, and community settings, and deliver evidence-based interventions earlier and more consistently and support families in navigating complex systems. We propose a six-pronged strategy to develop and or enhance partnerships across our community, state, and region. Integrating community partnerships, such as expanding school-based programs, collaborating with community organizations and support structures for behavioral health, including peer support networks, family advocacy groups, and faith-based or culturally specific organizations. Leveraging these partnerships will help ensure children receive care and help where they are, thereby improving ultimately academic performance and even catching behavioral health issues earlier. We also need to consider cross-state and regional collaborations to increase access and placement opportunities. Second, academic and provider partnerships are going to be vital to this effort. We suggest deepening the collaboration with Washington University School of Medicine and regional hospitals and partnering with local universities, colleges, and technical schools to create behavioral health workforce development programs, internships, and scholarships. Continuing education collaborations with professional associations will help address provider shortages and ensure staff are trained in trauma-informed care, crisis intervention, and cultural competency. Third, there may be opportunities to develop residential and step-down care partnerships. This will require that we formalize relationships with therapeutic residential programs and intensive outpatient providers, including those serving children with developmental disabilities, to increase capacity and reduce wait lists. Cross-state agreements and partnerships with foster care and child welfare agencies, especially through programs like Show Me Healthy Kids, will provide specialized behavioral health support for foster and adoptive children and improve transitions for those medically ready for discharge but lacking safe placements. Next, we have an opportunity to develop primary care and pediatrician partnerships. We can help empower pediatricians to manage behavioral health needs, supported by specialist consultation and technology innovators. Integrating with primary care through digital mental health platforms and telehealth partnerships can extend services to rural and underserved areas, while collaborative care models and ongoing support will improve access, reduce stigma, and increase engagement. Next, and importantly, government and policy partnerships we will need to leverage both locally across the state and federally. We can leverage our regional leadership position to advocate for innovative payment models and to work with public-private funding partners, including legislative advocacy groups and grant-making foundations, to secure funding and drive systemic change. Partnerships with foster care and child welfare agencies, as well as policy and advocacy coalitions, will help the organization proactively address behavioral health needs and influence policy for long-term sustainability. Finally, we have an opportunity to develop technology and data integration partnerships through things like integrated electronic medical records and analytics by collaborating with EMR integration vendors and technology companies. Digital mental health platforms can offer app-based therapy, crisis intervention, and care navigation tools, improving access, care coordination, and outcomes measurement across the system. Through these and other partnerships, we expect to see shorter wait times for behavioral health appointments, fewer emergency department visits, and inpatient admissions for behavioral health crises, higher rates of treatment completion and follow-up, improved patient and family satisfaction scores, better academic and social functioning for children served in schools, and reduced staff burnout and turnover, leading to more consistent care. Now I'm going to turn it over to my colleague Haley to discuss some proposed strategies.
Thank you, Chad. So for strategies, St. Louis Hospital and BJC already have a great foundation for academic partnerships as well as current staff retention rates and turnover. They can build on this foundation in a variety of ways to offer the most collaborative efforts towards achieving an integrated behavioral health department for both their inpatient and outpatients. So for my first strategy, it will be obtain more recruitment pipelines. And like Chad mentioned, the academic partnerships is a big one. They could also offer more residency and fellowship programs specializing in behavioral health departments. And they can expand their recruitment efforts to offer relocation bonuses, sign-on bonuses, and other incentives to attract those from out of state to come to their facility. They should also market their mission and vision when they're recruiting to those potential providers. The next strategy is enhance current staff members' retention. We can do this by obtaining the current workflow status from employees and responding to their concerns appropriately, which is a big one. So addressing the current staff members' issues. Next, we can hire more support staff, such as case managers and behavioral health technicians, to offset the workload. And last, develop career advancement ladders for current staff members, offering the highest performers a financial bonus. The next strategy would be expanding care to the community. One way they can do this is offering educational seminars for non-behavioral health providers to be able to recognize and treat these health concerns prior to a crisis. So you're looking at, like Chad mentioned, the pediatric providers, primary care providers to catch the problems upstream before these patients are in a crisis. Next, they could expand telehealth for rural patients and follow-ups. This also improves the retention and staffing due to the flexible work schedules for them. And then lastly, under this category would be collaborate with schools to offer educational support classes as well as education for the school counselors. So this would look like classes discussing mental health, behavioral health, and ways to address that, again, before it gets to that crisis state. And then in the counselors, ways to address that in their students. And then for my last strategy would be lighten the burden on educational barriers. So you could create a student loan repayment program for those offering service commitments to your facility. And then you could also streamline the onboarding process for faster credentialing of providers so they're able to treat patients quicker. Now I'm going to turn it back to Emma to discuss the 5-year plan.
Thank you, Haley. So, EVHC consultants, we recommend for BJC and St. Louis Children's year one to identify their problems, create goals, network. What do they want to see in their future? What are they seeing problems with? What do they predict their problems to be? Who do they want to see and who do they want to collaborate? Who aligns with their mission and vision within their community and so on. This is also sort of how I mentioned earlier, bringing on a chief of pediatric behavioral health to kind of oversee that department and that blend between both BJC and St. Louis Children's Hospital. And this chief of pediatric behavioral health will be responsible for creating efficient policies and workflows that are expected from their employees. Year two, we expect to see the board that I also mentioned earlier, create the board of behavioral health and managers from behavioral health departments. We want them to collaborate and see what areas, how can they learn from each other, and how can they come together to create the most efficient system, work with the chief of pediatric behavioral health, and how can these two organizations align and shift and be a cohesive workflow. We also want to evaluate our progress of the local and national trends to date and create these partnerships as previously mentioned. By year three, we want to expand these partnerships. So the academic, residential, step-down community, we want to not only network and create them, we want to expand them and reach as much as we can with our systems and our partners in the community and so on. We want to explore the financial offerings, sort of how Haley mentioned previously, so we can make sure that our workforce instability sort of stabilizes. We can't be a hospital without our employees, so we want to offer them as much as we can, where we can, and when we can. So exploring these and evaluating this continuously. We want to make sure that we are exploring every avenue and our trends are heading in the direction we want. Year four, we want to expand into governmental and policy partnerships. So not only do we want to expand into community, step down, academic, residential, we want to partner with government. We want to expand. We want to be the name, the face. We want to be as efficient as we can. And of course, continuing to evaluate progress in our trends, making sure they're still heading in the direction we would like. Lastly, year five, make any necessary changes based on the performed assessments. So year 1 through 3 will be our biggest changes that we are expecting to make. In year five, we need to kind of reflect and make sure they're heading in the correct direction and we are where we want to be. That still aligns with our mission, vision, goals, etc. Same with reassess current state of affairs and judge our metrics. So revisiting our goals and making sure that our dashboard is reflecting correctly of what we were wanting. Is our wait times down? Is our patient satisfaction up? Um, evaluate progress, national and local trends to date, continuing always evaluating that continuously. So this is what EVHC offers and recommends for BJC and St. Louis Children's hospitals. Thank you.
Thank you.